Well, it's a good thing to see Rafael back on the campus. It's been a long time since he was here, and he came from Venezuela, where he trained as an engineer, electrical engineer, and wanted to, very much like me actually, wanted to advance his skills in engineering and science. Came to Case Western because he felt at the time that was one a good place to be, and he's right. Then he got a PhD with me in 1999, I think. Is that right? Then got a job offers from Medtronic, turned it down, went to Advanced Bionics. I don't know how many years he was there for, but he developed there the first rechargeable Bion. At that time, if you recall, you were powering these devices externally. And so he developed a system to put a battery inside the Bion and a rechargeable battery in the system to power it. Then he moved to Boston Scientific. I can't remember what year that was. But he's now the vice president for research and development in the neuromodulation area. And he's pioneering a lot of new technologies for the company. And it's a pleasure to have you. Please tell us what's going on.
So when I was graduating, finishing my PhD, and I got this job offer from Advanced Bionics, and I tell Dominique, yes, they're developing this Bion, which is a tiny micro stimulator, like 3 millimeters in diameter, 2 to 3 millimeters in diameter, and about 20 millimeters in length. And Dominique tells me, wow, yeah, that's kind of like a neat idea, but how are you going to power that? I don't know if you remember that. That's what you told me. How are you going to power that? And I look at him and said, that's what they hired me for. So clearly, it was much more difficult than I knew at the time. If I would have known it, I probably would have second thoughts, but guess what? We actually got it to power. So it's actually great to be here. It is, obviously, last time I was here, I was facing the opposite direction in a very different room. But so truly it's an honor to be here, I can tell you that. And, I wanted to talk to you. I thought, if I'm going to come to a university where you guys are the ones that are inventing everything about neurostimulation, maybe I give you the perspective from industry. Essentially, how do we develop products and the type of roles that people can play in industry. So we are not the dark force or the dark side. We try to really help people as well and develop good science. So I like to give you that perspective. And as I was coming here, I thought, hey, maybe I'm going to teach you what we do in industry. And I'm thinking, to any other place I would go, I would talk about teaching. But to Case, really, they should be teaching me. So that's what I did last time, and it worked out pretty well. So instead of trying to teach what happens and how do we develop our system, the way I'm going to do this presentation, I'm going to need your help for that one, is I'm going to try to present you the problems that we were facing at the time as we developed the field of spinal cord stimulation. And I'm hoping that the good technical folks from Case will come with the same solutions that we come. So let's see where we arrive. But I bet they're going to be pretty similar to the products that we have today. And I think it's going to be pretty interesting. So it can be a pretty fun type of activity if you guys want to participate. And it can be horrendously boring if you don't, because I'm going to sit down until you come with the answers. So we have an hour. You're hostages now on the meeting, so might as well make it fun. That would be my advice. So, all right? So who thinks that Boston Scientific makes calculators? Okay, well, I'm glad that nobody does who thinks that we don't. This is the time that if you actually have an idea, you would raise your hand and participate. Not a tricky question. Who thinks that we don't make calculators? Okay, still? Cheryl, we got one person who knows that we don't make calculators. It's true, we don't. This is what we do. Boston Scientific is one of the large medical device companies in the US, and we are, if you have to look at us, you probably look at us into three big group of products. One group of products is the cardiovascular products, which are in red over here. Okay, I did something wrong. Okay, in red over here. And the cardiovascular products are intended to treat, obviously, the heart. And when you see, like, for example, the aortic valves, the stents, both directly in the heart as well as in the periphery with peripheral interventions, we are leaders really in this field. We're also leaders in the rhythm management group, which is in purple. And rhythm management is also for cardiac diseases, but in this case, we're trying to, it's a completely different technology. So in rhythm management, we have the pacemakers and ICDs and CRTDs, and we have pretty advanced technology. We have one ICD that is actually subcutaneous, and you don't have any leads in the vasculature. So it's all done subcutaneously. And we also have an electrophysiology division, part of CRM, the rhythm management group. And what they do is they detect the activities in the heart you measure, and then you ablate those areas that can be causing arrhythmias. And the last group, which is this one here, is the medical surgical group, and med-surg. And we're the leaders in endoscopy, we're the leaders in urology and pelvic health, and we're also leaders in neuromodulation, where I come from. So that gives you a general idea of what we are. It's a pretty diversified company. It's really a great company. And but the reason why it is a really great company is because of this, the mission. You probably imagine that when you're in a company, the only thing you want to do is money. If that was the thing, the mission probably say we want to make a lot of money for our investors. That's really not what the mission is. When you walk around the halls, this is what people tell you why they work for Boston. And I know it's true because I did ask the question. I literally sent an email to every employee in neuromodulation and asking why do they stay and work with us? Why? Why do you do this? And the number one and number two reasons why people decide and stay with us. Number one is because of the mission that we have. The real desire to help people. It's a focus, and it's crazy focus, because when you understand that you're helping other people, you work with a sense of urgency that you wouldn't get any other place. I mean, you understand that every day you don't have a product in the market. There is somebody else that is getting the wrong product or the wrong treatment. If you have it in your hands to help somebody, you want to do it. The other element that came on the top is caring for each other. So it's a great culture in which we're really friendly, try to help each other and so forth. But we believe it, and in fact, you can change that name, Boston Scientific, and put my name, and that's where I'm from. And truly dedicated to transforming lives with innovative medical solutions for patients across the world. And for engineers and scientists, I can imagine that the way I feel about it is I feel that I want to get to the edge of technology and knowledge where humanity has been, and then you want to go, well, hopefully not to the floor, but you want to push it forward and advance that technology a little bit more, right? But I don't want to do that just by making a phone or a better TV. I want to do it by helping people. So that, a month from now, there's going to be hundreds of thousands of people sitting around the table, and they're going to be giving thanks. And I know that these people don't know me, they don't know my team, they don't know any of us, but I know they're going to be thanking us for what we did for them. This is a great feeling, super fulfilling, definitely worth the effort. We work very hard, but it's a great feeling. So that's what we do. Now, in neuromodulation in particular, what we try to do from a technology perspective is what we believe is that we're building technology that interfaces with the neural system. And the neural system, being the main information pathway of the body, is really a great point of entry. I mean, depending on where you decide to modulate, you can have very different impacts anywhere in the body. I know that endocrinologists are going to tell you, well, maybe it should be the hormones or something. But I mean, we're here surrounded by neuro geeks, I assume. So we know it's the truth. So this is at least what I believe, and this is the type of technologies that we like to develop. So even though we're starting with spinal cord stimulation and deep brain stimulation, the reality is that these are technologies that can be applied in many other different areas as the field is going to progress. I mean, I do believe that we're still in the middle ages of this technology. And in Boston Scientific Neuromodulation, I may use other names every now and then. I may call it Neuromod or BSN. So the same. We have two main franchises. One franchise is the pain franchise, and the main products that we sell there are spinal cord stimulators for chronic pain, and RF ablation systems also for the treatment of pain. So essentially, you try to ablate those nerves that cause pain. It's less invasive, obviously you don't have an implant. And we have another franchise, which is the deep brain stimulation franchise. We are not approved in the US. This is commercial pretty much everywhere else in the world. We're doing our studies in the US. And in this case, we're starting with movement disorders. But we all know that deep brain stimulation is essentially going to evolve in who knows how many new indications that are being researched right now. So it's super interesting. And in this field, I mean, just to give you an idea, we are the #1 CS company in the US. We are known as the technology leaders when it comes to targeted stimulation. I think that's pretty clear. And our vision really is to disrupt essentially any market. We want to be the ones that invent the new things. We want to be the ones that bring it to patients. We want to be the ones that transform their lives. So that's why we're not afraid of changing us or changing the space. So it's super exciting. Now, let's go to the real thing. So let me go back in here. So first question. You guys ready to participate? So let me just promise you this. If you don't have an answer, I'm literally going to sit down, okay, until somebody comes with the answer. It's not a tricky question. It's very easy. They're going to get more difficult as we progress, but this one should be pretty easy. The one about the calculator was even easier. So I'm disappointed just to start. It's just less. So it's a chance to. I'm walking, or you're walking down the street. You stomp your feet or your leg against something. What's the first thing that you do? What is it? Curse, #1. What is the second thing that you do? Not that tricky. What's that? What do you do?
Rub it.
Rub it. Who said that? Yes, there you go. You rub your leg. Does it work? Where does it work? Takes the pain away. Right? So somebody figured it out many, many years ago. You stamp your foot, your leg against something. If you rub it, the pain goes away. Right? So now it's very simple. Pain, rub, goes away. There is somebody that actually said it a little bit different. And if you say it in a manner that sounds like this, it is apparent that activation of sensory afferent fibers inhibits the transmission of pain signals going to the brain. Suddenly sounds like a great theory, right? This is actually the same thing, but it sounds like a great theory. Well, that theory was proposed in 1965 by Melsack and Walsh, and it's called the gate control theory. And it's truly what it says. And in that time, in 1965, after that was proposed, there were some researchers, essentially Shiley was a doctor, who actually thought that, you know what, maybe there are patients who suffer from a chronic pain that is intractable in any other way. And maybe we could have an answer for them if we were to provide strong afferent stimulation. In that place, where's the afferent stimulation or information going to the brain through the dorsal columns of the spinal cord, and say, well, maybe we should stimulate in the dorsal columns and to treat this chronic intractable pain. Now, this is not just a little pain for a few people. Just to give you an idea, the estimates about how many people suffer from chronic pain in the US, I read varying numbers, but it goes from 25 million all the way to 100 million in the US alone. This is chronic pain. So you can see it's something that really affects a lot of people. And with that idea, there was a group of courageous people that decided to experiment or try this for patients that had no other alternative. And in 1967, they implanted the first patient with a spinal cord stimulator, which is that first step in 1967 is what gave origin to what is today an industry that is north of $1.6 billion that is helping several tens of thousands of new patients every year. So you'll probably be glad to know that that first spinal cord stimulator was actually built by a PhD student from the Case Institute of Technology, and that the student is Dr. Tom Mortimer. So literally, the first stimulator in the planet, spinal cord stimulator, was created by him. So very honored, essentially, to be here. And we actually do this. I had to verify with him that it's actually really true, because we always tell this story and say, yeah, it's actually true. So thank you very much. I mean, literally, there are millions of people that are sitting around the table just a month from now that are going to be thankful for what you did, and I appreciate that, changing the world. So now that first stimulator this is how it worked. What they did is they did a subdural procedure. So they had to, the surgeon, Shiley, had to actually remove part of the bone in the back of this patient. It was a relatively big procedure. Expose the spinal cord, which, you know, it's kind of delicate. Open the dura, obviously, and put the one electrode, just one shot on goal, in the spinal cord. And then that electrode had one wire attached to it that was externalized from the skin and connected to an external stimulator. You would imagine, okay, that's a pretty courageous step, right? But it did work. It did work. That proof of concept did work and gave origin to this type of industry. But you can imagine, a product like this is not commercial. You cannot really offer this thing to tens of thousands of patients every single year. Now, what I'm going to ask you is, what things will you do to this product to make it better? Just explaining some of the caveats of this one. What will you do to make it better? What's that?
You gotta implant the stimulator.
Implantable. You don't want the wire coming out. Good. What else? Make it smaller. Why would you make it smaller?
So you can minimize the risk in a surgery.
Got it. Minimize the surgery. Yes.
Yeah, less invasive.
Less invasive. Yes. I mean, you got it all. What else would you do?
Refine targeting.
What's that?
Refine the targeting of it.
Define the targeting.
Refine.
Refine the targeting. Yes.
Use the stimulation channels.
More channels. Yes. What else?
Improve the overall function. I don't know what the sensation was of the original, but
Got
if
it.
you can make it so it's not paresthesia.
Now you're going several generations ahead. Yes. So, okay, let me go to the end of the slide then, because you guys really are faster than that, but I'm going to take some of them. Let's assume you didn't mention so many good things. So, but let's say you want to put refined targeting. You want to have more shots on goal. You want to make it less invasive. You want to make it implantable so it's not coming out. And all those, and essentially, these were the next steps, the obvious next steps that were created to make a commercial indication. This is what I call the modern spinal cord stimulator system. And in this case, what you do is that we don't actually put the electrodes subdurally. Subdurally, what we do is we put the electrodes over the dura, so it's still within the protected bony aspects of the spine, but we don't put it subdurally. We're actually above the dura, and we let the electricity actually go down and stimulate the dorsal columns. It is minimally invasive, so what we do is, in most of the cases, you actually use a needle, and you pass a lead through the needle, just like an epidural, for women that are delivering, and you insert that needle over there, and then instead of having the wire coming out of the skin, which we do that actually for trials only for a few days, the device is actually connected to a generator that powers it. So essentially, you don't need to be attached to an external machine, and instead of having a single shot on goal, we do refine targeting, and in this case, you put more channels or more electrodes. So what you mentioned is essentially what happened. And this type of improvements is what led to the commercial development of spinal cord stimulators. So let's see what happens. So does that make sense? It should, because you guys invented it. So it should make sense to you. So what happens with this type of therapies? Did it work? Yes, these are the results of that. So there was a paper from Kumar, 2008. This is part of the process study. So these are devices that were developed, let's say, in that period, 1990s and early 2000s. And this is 24-month follow-up. So just to give you an idea, this is the time, and up to 24 months, and they're following up 42 patients. And what you see in the vertical line is a measure of pain. In this case, what we're using is VAS, visual analog scale. So the state of the art for pain measurement is a ruler that has a happy face on one end and a sad face on the other end. Happy face, no pain. Sad face is worst possible imaginable pain. Right? You point with your finger where you are, and that tells the investigator how much pain you have. So I normally go from 0 to 10. In this case, they go from 0 to 100%. Okay, but let's assume that I like to say 0 to 10. So if you see me talking about 1 point or so, it's actually 10 points in this scale. So what you see in these patients, when you put a spinal cord stimulator, 24 months later, most of the patients have statistically significant reduction in pain. And they go from a severe amount of pain, typically severe is 8, 9, 10, 80, 90, 100. And then they drop to about, let's say, 45 or so. Okay? So it's very significant reduction in pain for leg. So leg is actually pretty easy to treat. But when you go to back pain, low back pain, a very significant cause for people essentially missing work and essentially being disabled, what they concluded is that it really doesn't work. That type of technology did not provide any advantage. So in that period of time, people believed that it wouldn't work actually. So most of the patients that were implanted, look, it's the same end. Most of the patients actually do have leg pain and some component of back pain, but they would implant mostly the people who have mainly leg pain and not back pain because they couldn't do anything really about it. But and that's kind of like demonstrating here. They started with about a 55 or so scale average in terms of pain, and then they dropped to like high 40s, so it's not statistically significant. So as you see, it didn't work for back pain. And that's what we were thinking when Advanced Bionics was essentially being formed. And the problem is something like this. What we were thinking about is that, well, maybe we're not hitting the right targets. Maybe back pain is a little bit more difficult, and it's true. The fibers that innervate the back are actually smaller in size, and they are more sparse, and they are distributed kind of deep within the dorsal column, so they're very hard to target. So we're thinking that maybe we're missing some of these targets. So if you see this example, let's say that we had to hit these fibers that are in this area of the dorsal columns, and then if you have one electrode and you put your power in here, then this is what you hit. But then if you switch to the electrode, maybe you hit in here. And then probably we're just missing the target. So faced with this situation, remember, this is the pulse generator. It has a power source, and you can connect the power source to any of these electrodes. What would you do? What is the next step? Connect it to both.
Yep.
Right? Very obvious choice. Let's do that. So now we connect it to both, and when you connect it to both, what happens? Where is the electricity going? Who knows? How do you know where it's going? You have one source in here, and the electricity now has to choose where to go. So how does the electricity choose? Well, the electricity is going to choose to go through the path of least resistance. Guess what? Ion seems to be smarter than we give them credit for. So maybe they are smarter than I don't know, maybe some undergrad students, I don't know. But they seem to be pretty smart. Because if there is an area, for example, you have a high impedance, they don't want to go that way. They're going to go through the other electrode. So you may say, well, I'm going to connect them to both, and when you do that, you think you're going to be hitting the target. The problem is that you don't control that. Even if you control that, what is it that we want? Our goal is to stimulate what we need, to avoid stimulating what we don't need, because if you stimulate what you need, you can have side effects. Right? In fact, if you stimulate what you don't need and you turn stimulation up, what is going to happen is that it's going to become annoying and you never got your target. So, and then the other part that you want is you want to maintain stimulation over time. So it's not that you trial the patient today, you go through the surgery and it works for them today, but 6 months from now it doesn't work anymore because there is impedance growth, there is fibrous capsule formation and so forth. So think about these three elements. Now the question is, and by the way, let's say that there is no impedance. Let's say that it's constant. What guarantee that you have that you connect into both and the 50-50 distribution has to be ideal? You guys are in biomedical engineering. When does nature work that way for you? Never, right? There is something like something's going to be better than something else. So it's very unlikely that the 50-50 is going to be perfect. So clearly there's got to be something better. What would you do? Jose, who's cheating here? You know the answers, right? So, but what would you do? So yes, current control is one, but current control how? You're still going to put a source that is current source. So this is a voltage source, but you can still put a current source. Sorry, a current source, and the current will still choose the path. It's going to be a little better. So I think you know the answer, though. You're saying more channels, right? So you say it's like exactly that. By the way, normally I wouldn't expect the current control, so I was gonna give you a clue I thought that maybe I was gonna get, you need more channels. You need one channel for each electrode. Then I was gonna ask you, hey, what kind of channel would you use? Would you use voltage and current and say, hey, you guys need a clue? Activating function, obviously, that is the clue. It depends on the current of the electrode, so that's really the way to control it. But that's the problem when you come to case, I guess. You guys know it. Well, this is the problem that that is exactly the answer. So what you do, you put more channels. Like, it makes no sense to have a single source to power 2 electrodes. Why don't you put a power source for each electrode, right? And now you can control them independently. So if one has a lot of impedance, it doesn't matter. You just give it higher voltage to maintain the current that you need, and now you have a balanced approach to whatever you need. So that is the solution that another case graduate came up with. I mean, it's kind of funny. I mean, you guys are coming with this answer, but you know this answer. And that was Dave Peterson, also from, at the time, the Applied Noise Controller. So Dave actually came, hey, this is what we need to do, and this is what Advanced Bionics tried to do. And we developed it in 2004. By the way, when I was interviewing with Advanced Bionics, they were telling me what they were going to build, and they said, oh, we're doing an SES, and it's going to have like 16 electrodes, and it's going to have current steering and multiple independent current control. And I'm looking at the mechanical engineer who was explaining that to me because he's building it. And I'm looking like, he's coming from another planet. It's like, of course you're going to put independent current sources. It's like, how else will you do it? I mean, like, I couldn't understand that it is like so logical that this is what you need to stimulate it. But the fact is that it's very strange, but we are the only company that has this. All the other companies, they have a lot of electrodes, but they still don't do this. They have one source that is attached to share between different electrodes. So you guys just invented what we call MICC, multiple independent current control. So it is a basic principle. I mean, for somebody who studies neurostimulation, you would say, well, that makes a lot of sense. And the way it works is something like this. So, by the way, another thing that we did is we actually put a lot more electrodes. So in the market, there used to be essentially a contact system, 2 leads, 4 and 4. And we said, well, you need to blanket that. You need to put more electrodes to ensure that you can really cover. And without independent current control, you can actually change the amplitudes by 1%. You can literally move current in 1% increments between electrodes. And then that gives you the ability to steer the current to try to fine-tune in the target. You see that? So obviously it's a cartoonish representation of what it is, but each electrode has its own contact, and obviously it is designed to produce the control over the electric field, precise target of stimulation, and the immunity to the impedance just because it's a current source that is independent. Does it make sense? Should. You guys just invented it. Okay, so let's see what happens in the real world. Today, we not only move to a 16 contact system, it's just the standard really in the US. At least, you have to use at least 16 contacts stimulators. And in reality, we have also a 32 contact stimulator. And I'll tell you the story how that came up a little bit later. And you think, wow, that's amazing. You build a 32 contact stimulator, 16 contact stimulator, nobody else has it, they only have a 16 with a single source, you're going to have everybody understands that that's the way it works and everybody's going to use it. That's not true. And in fact, when you see this, the advantage of this system is that it has independent sources, a lot of them, so you can control stimulation. The disadvantage of this system, and this one, the disadvantage is really so simple. It has a single source. It's too simple, right? You cannot do it. The disadvantage of this system is that it has 16 sources or 32 sources, and it has a lot of control. The advantage of this system is that it's very simple, it has a single source, and a few contacts or few combinations is very easy to use. You get that? It's like, yes, you make something very complicated, and the previous game of programming, who's going to be using this system? A doctor is going to implant the thing on a patient, or you have a field clinical engineer helping, and before, you're playing Battleship. Well, let me connect this electrode to this, and connect this electrode to that. Sync? No. Okay, next one. Well, let me connect this one and that one. Okay, that's fine. When you have a simple game, you can play Battleship, and it's not overwhelming, so this is the Battleship operator playing with electricity in the cathodes. It looks like this. If you actually look at the software, it really looks like this. You've seen it, Carbunaru. It's probably something like that. It's nothing like what Cameron, the type of software that Cameron develops for programming. But you see that you can build the sources, you can build the engine. If you don't make programming adequate, if the users are unable to use your product or your invention, it's useless. It's great. Well, no, you can get a PhD thesis on that one, maybe the Nobel Prize. But it has to be used, right? I mean, at the end of the day, you want to get to that point in which hundreds of thousands of people a month from now will be thankful for what you invented. At least that's what drives me. So the next big step is essentially to do a software that allows you to program a very complex system. And we spend so much time on that one. You have no idea. That is probably the area we spend most of the time. It's easy to make a stimulator. We can do that. You get a good electrical engineer, a good mechanical engineer. They know how to package everything into a hockey pack. It's not a problem. The problem is the usability. And that is something that is very hard to understand until you actually see it. So that's the next question to you guys. It's probably getting a little bit more difficult, although you really are answering way faster than I thought. How do I program a 32-contact system in a manner that is elegant and easy? Now you have 32 contacts, and you can change current by 1% increments. How do you play the Battleship game?
You have to create a model of the electric field, a model of the neurons you want to stimulate.
And then? That's good. That's very good, actually. It's a good starting point. Just build around it.
You have to test that model.
Yes? Think about the user. Got it. You build a model of the electric fields. You build a model. You're thinking like an engineer right now. You're thinking an engineer from case right now, by the way. This is not the kind of stuff that you actually get in other places. I'm telling you, it's for real.
We got to involve the user in the process.
Yes. What do you expect the user to do? What do you expect the user to know? And what do you expect the user to need?
He knows what hurts.
He knows what hurts, yes?
He knows what hurts less.
Okay, good. He knows what hurts. So he knows, if you go that way, it's like he knows where he wants stimulation, he or she. Or the doctor knows where he wants stimulation, what information they have. So that's one of the information. So they know where to go. The other information that they have is where the electrodes are. So you guys just literally put together what the algorithm is. And it's amazing. I was going to give the story about the GPS system. Essentially, I'm telling you, this, honestly, you can go to a place and you won't get these answers. It probably sounds easy to you, but it's not common. In a GPS system, what do? You know where you are, and you tell it where do you want to go. And what does the GPS tell you? Turn right here, turn left in here, this is the time, whatever it is, right? That's what it is. You don't care, honestly, what city you are. Who has to take a map of any city anymore to drive? I remember I used to grab a map and find out. Well, okay, got it.
I don't trust GPS.
There you go. So I do trust the GPS a lot. So you're part of the 60% of the people that don't use us. So, the reality is that I don't need a map anymore because I don't need to know where the streets are. I don't need to know anything. All I need to know where I want to go, and I need to tell you where I am. That thing will figure it out. That's the thing. You know, doctors are not electricians. They shouldn't be electricians. That's not their problem. The problem is to treat the patient. That's the way we're thinking about it. So what we do is exactly what you guys mentioned. So number one, we do have information. The input is where in the spinal cord do you have electrodes? Another input to the algorithm is where do you want to stimulate within this space? So you select a point in here, right? And then you have an algorithm that you were describing, and you use essentially the inverse function of that, and then you can come out with a combination of electrodes essentially to get the central point of stimulation right where you want it. It's yeah, makes very good sense if you come from case. I mean, that's honestly, really, you guys are doing these simulations. I've done simulations like this. Cameron, you don't simulate. I mean, I'm pretty sure, like, Dominique, I mean, remember when I was here, it was Jim Kavanaugh doing this type of thing and so forth. It was like, yeah, it makes a lot of sense. And of course, what is the algorithm is essentially what you guys are talking to. By the way, imagine that picture of the lady with the cables trying to get a combination like this. Well, I want to put 12% anodic current over here and 20% here and 5% here for cathodic. They will never come with that, right? So it's not possible. So let's go a little bit through the algorithm. By the way, who solved this algorithm, who created this type of algorithm? 3 case graduates. Dave Peterson, Mike Moffett, and Dong Chul Lee. So they create the algorithm. By the way, we have an army of software developers that are actually making this thing very pretty. But since we're geeks, I'm not going to go to the prettiness right now. We have no time. But I can show you two later. So the algorithm is what you say. First of all, you model the fields. Yeah? Then you model the anatomy and the nerves. And we do model that. I mean, we literally have a model of the spine. We have a model of the axons and the different fibers going into the spinal cord. And then we model the fields. And based on that, you calculate the activating functions. And you do essentially an inverse problem. You say, I want the activating function to look like this. What are the electrodes that need to be activated in what type of fractionalization of the currents to create that type of activating function? It's the inverse problem that we can solve, and we solve in the algorithm, and that's exactly what we do. So you take the fields, you take the models, you predict what is the activating function that you need. In fact, you do it all backwards. You know what the activating function you need, and then you go backwards and you get there, and that tells you what is the combination of electrodes. And once you have the combination of electrodes, then you apply that to the engine that have the multiple independent current control, 32 contacts or 16, depending on how many electrodes you put in there, and applies the answer. So logical, huh? Again, we're the only people who has this. So by the way, I'm looking at this reference. Johan Struik was with us he came for like 6 months or so to case the 90s. Yes?
Is there anything in the algorithm that takes into account the uniqueness of the patient?
So that's a good question. The answer to that is we don't have MRIs for the patient. So we don't do that in SES, but we do that in DBS. So in our DBS software, we do have considerations for that. So it's the patient's MRI and CT scan and the actual placement. The only aspect that we do have that is personalized in this case is in this part in which we copy or clone within the system, we inform the system the particular leads that the patient has and the relative positioning of the leads. And the reason that it probably can be important. What we say is that, I'm not going to show you the algorithm, but let me pass on that one. In SES, it's very easy to get feedback from the patient, so it provides you a very good starting point. And the patient say, oh yeah, that's perfect, or move it to the right or to the left. The amazing thing is that when we launched this product in 2013, the reality is that we actually designed the algorithm first. Because we're thinking, how do you get to low back pain? And they say, we need a smart algorithm, something like this. And then you calculate back and say, well, to get these fields, we need now a 32 contact system because we need this many electrodes. And guess what? That didn't exist. So we need to create the IPG. It was completely the opposite. We started with the target, then the algorithm. And so it's pretty interesting. And but we, in 2013, developed this system, and which is the Spectra system. It's this IPG. 32 contacts is the only 32 contact device. Most of the devices are 16 contacts. And we have a whole bunch of different type of leads, even leads with 32 contacts, leads with percutaneous lead with our 16 contacts. And the Spectra system is essentially what we use the workhorse, provide the best therapy, the most flexible system. But there are two other products that have that's also pretty powerful. The Montage system gives you whole body MRI. So you can get an MRI on any part of your body for those patients that would need it. But it's 16 contacts. So your trade-off here is 32 to 16 contacts. And it has to be used with this lead only for it to be MRI. That's the Avista lead. And we also have these two devices are rechargeable. So they are around 20 or 21 cc's in volume, very small. This device is primary cell. So if there is a patient really that you think will have difficulty charging, then you may want to give him a primary cell, or is a very low power user, then you might want to give him a primary cell device. It's larger in size. I think it's around 30-something cc's Don't remember the number exactly. So it's obviously bigger than these ones, but it's actually pretty thin. So, and of course you have the software that we call the Illumina 3D software, and externals like a recharger and a remote control for a patient to adjust stimulation. And we worked for about 7 years to come here, because we start thinking on the spinal cord first, then the algorithm, and it took a long time to come here. And here we come in 2013 and launch the thing, and we have no idea if it's going to work. So this system that you just created, literally, you're the ones that are coming with the solutions. You want to know, did it work? Let me show you the results. So this is data of 24 months. This we call our Lumina data for precision spectra. And look at these rates. You remember the previous results that I showed you, the standard of the early 2000s? So what happened in 2013? The therapy has changed at all. And we use a different scale. It's the numeric rating scale, 0 to 10, but I think you can do the math, right? So these are usually the numbers that I use. And you can see there is a new level of performance. So for overall pain, we go, instead of previously what we saw, is hard to compare studies, right? It's not really fair because different patient population and so forth, but in general. The level of pain that we're getting now, it's not in the 4.5s, but essentially we just drop it by a factor of 1 or 1.5 points below to where it was before. So 0 to 3 is typically considered like minor pains. And so we are around this range. This is very severe patients. You still drop the pain by 5 points. So it's a very significant decrease in pain. What is more important is that this is a large patient population, 213. In this study, we did not exclude any patient. In particular, we did not exclude patients who only suffer low back pain. Remember, those patients were not even included before. Essentially, some patients have some amount of back pain, but they were mostly leg pain, and the average was still 4.5. In this study, we had 89 patients who only have low back pain. It's not like back pain, they were to the doctor because they have terrible low back pain, untreatable before. And this is what ended up happening. These patients responded just as well, pretty much as leg pain. So now we have a therapy for low back pain, something that was pretty difficult to achieve before. So, hey, you guys did a fantastic job. And how do you compare, actually? We have a previous generation system, the Precision, the one that we launched in 2004. That device, it was MICC, had the independent current control, but it has 16 contacts. And it didn't have this algorithm. Just didn't have it. We didn't know at the time that we're going to need it. And when you compare the performance of that previous generation system with the new generation system, what you're seeing here is the responder rate, i.e., what is the percentage of patients that get a 50% or greater relief from their pain. Does that make sense? A responder, if you get 50% or greater relief in pain. And what you can see is that in all, just overall pain or leg pain only or back pain, we did much better. So for leg pain, where you can treat, the increase is less, but it's still pretty significant. So now if you have leg pain, 81% chance you're going to be better. And if you have back pain, it's 71% chance you're going to be a responder. I mean, these are pretty amazing numbers, considering that it was not offered for back pain patients before. So pretty amazing system, right? So I'm pretty sure that you're probably wondering, well, I just created the best system anymore. Let's move to another indication because there's nothing else to do. That's probably 30 minutes, we're done. What do we do now? Okay, so what is the future? So the future is, well, let's talk about it. So what we did is that if you find the right target, if you're very careful about it, with the proper software and MICC, you're going to get the desired outcome. So what's next? And Dusty cannot answer this one. You're not allowed, Dusty, because I know, I read your paper. You're not allowed from May or so. So what do you think is next? Yes?
Taking the patient human factor out of the picture.
What do you mean?
Doing physiological recordings around the spinal cord and in other areas, and then tuning your algorithm and steering the electrodes to minimize the electrical response from other neurons.
Yeah. Okay, so you're really going a step even further. But by the way, this is not fantasy land. Yes, that's a very good one. It's on our site. What else? Who are you talking to? Who are you stimulating? What are you stimulating? Stimulating information pathway. What do you want to do when you get to the information pathway? What would you like to tell it? You want to speak brainish. That's what you want to do. You don't want to send gibberish, right? I mean, you think about it. You're talking to the most sophisticated system, and we like to say in the universe. I don't know any other planets yet, but for now, let's just say the ones that we know. Wouldn't you like to say something that is meaningful? So the concept of I'm getting to the right target. Now the question is, can I deliver the right payload to this target? Can I speak the right language to these neurons? That is the part that is interesting. And there is so much research going on waveforms. That's why I had to read Dustin's paper. So there is a lot. This is a new area right now that is developing in the spinal cord stimulation field, and there is a lot of talk about. So right now what we do is we have a system that can provide, it's actually very flexible, and it's been able to provide all these waveforms since 2004. But we have not systematically studied them because people have been literally stimulating between, let's say, 60 and 100 hertz typically. And what we're finding out is that some patients respond better if you actually send the stimulation via bursts, relatively high frequency bursts. Some people are experimenting with very long pulse width type of patterns, and some people are trying very high rates in the kilohertz ranges. So these are all things that are happening today on the field, and essentially is maybe offering a clue about different mechanism of actions that are going on. In fact, we did some of our studies with Spectra, and we find out that if you offer the options to patients, if you actually tell them, hey, why don't you try, we call it multi-wave. The thing is that you can imagine the complexity of programming now, not only the target, but the frequency and the patterns that you want to talk is another dimension of complexity. So we're still learning what patterns are important so that we can then engineer our way into simplifying that process. So we create a tool that help a user program a whole bunch of different waveforms on this patient. We call it multi-wave. And what we find out is that there is no silver bullet. Just like 72% of the patient, they don't want a single option. They just want to have multiple options. Pain just changes during the day. And the pain will change over time as well. So having an option, a single option makes no sense or appears to make no sense. Really, what we need to do is to provide a whole bunch of options. And some patients, those 72% of patients who prefer multiple options, some of them prefer the 1 kilohertz and the standard rate, some prefer a burst pattern and standard rate, or you name it. There are all possible combinations. And what is potentially happening is that when you actually do like PET scans of these patients, you realize that there seems to be different areas of activation depends on the waveforms that you use. Maybe indicating there are different mechanisms of action. So maybe pain is a symptom that reflects potentially different type of conditions in the patient. And you need then to trigger or to treat this patient with different pathways, essentially to cure their pain. Does that make sense? I mean, I think this is super cool. I just think is the concept that we're going to be able to speak brainish is just super exciting. And we will speak brainish. I know some people think it's crazy, but guess what? We used to make cochlear implants in advanced bionics. So in cochlear implants, we're not trying to just create gibberish in the auditory system. We're trying to help patients hear music. So when you hear music, you have to translate noise into a pattern that the brain can interpret as music. If it's a conversation, you can actually speak when there is a lot of noise and you figure it out. Music is not that way. If music is noisy, you turn that radio down. It's just annoying. So if you want to do it, you got to speak the language of the brain. So it is possible. We just got to figure it out. So that's very interesting. And obviously, what you're saying is absolutely true. Our next step will be personalized even better so that the system can, maybe you want to sense and so forth and find out how do you fine tune so that it's true. It's automatically done. Yeah. So now, again, 39 minutes later, I think, what time is it? Wow, we're almost done? Okay, so it took us about an hour to get to today in the future. And you say, well, I don't know why it guys takes you so long because I could have invented this in 1967 plus 1 hour. It's actually not that fast. To give you several general ideas, it takes tens of millions of dollars to develop these systems. Our first product, Precision, the one that didn't have the algorithm, just the MICC and so forth, we started development around 1998, and it got into the market in 2004. And Spectra, this concept of Spectra started probably as early as 2001, to be honest, some of the thoughts about it. But we really didn't start working on it really deeply, probably until, let's say, 2004, 2005. You know, these ideas evolve and so forth, so it's hard to pin it down. But probably it's safe to say that it could have taken us about 7 years to develop these systems. There's a lot of people that has to work on that one. And I want to give you an idea because for technical folks, you may imagine that there is only room for you in terms of research within a company like us. And so I'm the VP of R&D, Research and Development. And obviously the development is building these products, but we do have a research team too that does a lot of basic science as well. So, but there are other roles. For example, in marketing, remember that I mentioned the usability aspects? Somebody has to figure out. Somebody has to understand the user, having to evaluate, okay, can somebody press this button or that button? Will they actually know what it means? Can they get it right? Marketing has to do that. These are people that have expertise in this type of aspect. If you get it wrong, the products don't work. Obviously, R&D is kind of obvious. QA, this is quality assurance. These are also technical folks. And in quality, you can imagine this is the last guard protecting a patient. So they have to make those tough calls in terms of risk-benefit analysis. There is no medical treatment that is perfect, right? In fact, there is always a risk associated with any type of medical treatment. How do you know that is right? How do you get that is right? What type of information you have, particularly with something new that you don't know? It's difficult. Very, very difficult. So this guy has to think about that and understand what it is. By the way, there is also risk in not getting a medical treatment when you need it, right? So these are very tough calls. And they also have to analyze, predict reliability of our products and ensure that in manufacturing, nobody mess up something because we don't want to make one prototype or proof of concept. We want to make tens of thousands. So they have to make sure that our operations are really operating essentially very well so that we can guarantee that our products are safe and reliable for our patients. Another area is regulatory. This is a bit less technical, but these are the people that interface with the regulatory body, i.e. the FDA, TÜV, or the Chinese FDA, and so forth, essentially all over the world. In manufacturing, these are engineers as well. They have to create process to manufacture these products. Very technical as well. Program management, they are essentially ensuring that we execute the programs. Clinical research. You can imagine, yes, we need people there in the ORs, people helping doctors essentially to execute the clinical, the research that we actually pay for so that we can demonstrate that our products work or not, so that we learn new experiences, treat new conditions, etc. Obviously, we need people that are scientists for that one, and engineers too, because our devices are technologically, advanced initially, particularly when you are in clinical trials. Our sales force and field clinical engineers, they're also technically very competent. They are in the OR supporting doctors. They are in the doctor's offices when they have to troubleshoot the systems if something is difficult to use. So again, very technical folks. You can imagine that you realize that it's not just R&D. Really, there is space for a lot of people in a lot of areas in the company. And one good thing, though, is that when you work on a company, you can really play different roles. You can start in one area and then decide to move to a different areas. And it depends usually on the motivation of the people and the desire essentially to try one thing or another thing. We tend to be very flexible in that regard. So we're running out of time, I assume, so I cannot go to DBS. So let me leave it. Let me allow some time for one question. I don't know how much time we have, Andy. I have all day, so until 2:30 though, or 3. All right. Thanks. Questions?
Okay, so as we ask questions, everyone please wait for me to bring you the microphone so that the broadcast can hear too. So, you first.
Can you give us some idea of the competition? So the different designs. Neuros, St. Jude just had something coming up, right?
Yes.
Medtronic, Advanced Bionics. Can you compare those different? This is a very competitive field, so.
Yes, so right now I would say there are the players in spinal cord stimulation. I'm not going to talk DBS, just SCS. So we have obviously us, we're the number one in the market. Then, and you saw the products that we offer. Then you have Medtronic. They have been historically, they were the creators of this indication. I mean, they were the ones that pushed it. They have done great things for humanity, in fact, developing these indications. What they have in the products are still what I would call this type of modern era type of stimulator. They're single source, voltage control, and they are trying to experiment a little bit with waveforms with something that they call HD stim, which essentially means, yeah, you have a lot of flexibility in the pulse that they always had. So that's what they have, but they offer good quality product. Another competitor is St. Jude. And St. Jude recently launched a set of systems, but the main thing that they are bringing is probably two things. Number one is that burst pattern. So they did a study on burst trying to understand if stimulating with a burst makes sense. So I would say that our burst, we also have a burst. It's not identical, but it's also a burst. And in reality, our experience, I was hoping a lot more from the burst, to be honest, because it made sense to me that burst would work simply because of the effect of postsynaptic potentiation and synaptic reliability that you get when you communicate in that way. But the results have not been there. I haven't seen it. And if you see the result from the Sunburst study, it was not really exciting. But the other part that they have is something that they call, they acquire a company called spinal modulation, and they do dorsal root ganglion stimulation. So I'm hearing good things about DRG in terms of what it does for patients that have very focal pain that normally you think may be hard to just trigger that particular pain with SCS. So it's probably a niche product, but I heard good things. There are things I have to figure out, for example, how do you explant that lead, because I've asked doctors and they are essentially, I have no idea, literally, so they have certain concerns there. But I bet they'll figure it out. So it's interesting. I think that's an interesting thing. The other company, there are two more companies that are coming in the US markets that are very interesting, actually. Nevro is one, and what Nevro has to offer is 10 kilohertz stimulation. So instead of stimulating at between 60 to 100 hertz, they brought out to the market the concept of, let's go to very high frequencies, 10 kilohertz. So we don't know how it works. They had great results in their study. So, well, when I compared the results with our results, for example, for Lumen, I said, well, I don't see any, from a responder rate perspective and so forth, they're actually pretty similar. But the interesting part that never brought to the market is the concept of, they woke up these interesting waveforms, and in particular, stimulation without creating paresthesia. So that's very interesting. But I believe it's the beginning. It's not really, it's not the end. That world of waveform has to be explored. So that's interesting. We have a lot of science going on in there. The other, Banero is still relatively small scale in the market. And the other one that is an entrant that is starting to come, I don't think is not known at all, is one called New Vectra. So there is a company called Great Batch that they're essentially an OEM producer. So they build parts and serve medical devices companies. So they bring like feed-throughs or cans or whatever, they just built it. And they create their own company. They try to move up the value chain by producing full devices. So they're producing a full device called, I don't even know what is the name actually, but the company, what's that? AlgoStim. Yes, yes. So, you know, they haven't done really any industry. They're just starting. So that's pretty much how the space is getting interesting. I think spinal modulation is interesting, essentially bringing the concept of DRG, the wake up, the renaissance of this field based on the waveforms with the burst and the higher rate is interesting. So we do go all the way to 1 kilohertz, and we have published data also at 1 kilohertz, and while we don't see any big difference between 10 kilohertz and 1 kilohertz in terms of, and nobody can explain either what is the difference between those. What seems to be true though is that there is something about subparesthesia, And what I don't know is what is the floor of frequency in which you're going to have those effects. So that's something that we have to understand. So obviously Nevro is saying it's 10 kilohertz. We say it's probably below 1, but we have to understand that better. But when we start understanding the circuits, when we start understand how this thing is working, understand exactly what is being activated or inhibited or what exactly is happening, we'll be able to optimize. So that's why it's just the beginning. I don't think it's the end by any means. But it's pretty interesting, actually.
Sorry, we have a question from Sao Paulo. Bob
From
wants
who?
to know, from Bob Gershit, he's in Brazil. He says
Okay,
he wants to know if you can implant these devices in the cervical spinal cord for shoulder pain.
So it is off-label for us to implant in the neck.
Cheryl's waving her flag back there. Don't talk about it. Don't talk about
Yeah. So it is off-label use, but yes, it is not on-label. But there is obviously a lot of publications that speak in that regard, but obviously doctors need to understand that it's not approved, and even though they do it. Hi, Bob.
So I was wondering if you could give us, maybe changing gears a little bit off the technical and get more into maybe giving us some examples about how you would make a decision on, developing a new technology or the risk. How do you weigh the risk of, developing something new versus the cost versus the potential payoff versus, what's the calculation that goes through your head when, Moffitt comes to you and says, I want to do something?
So that's a great question. And I can tell you that we may not have been that sophisticated a while ago. We are very paranoid. If there is something better to be done, I want it to be us. Even if it's going to cannibalize us, our commitment is with better outcomes. So if there is something that we believe that can provide better outcomes with patients, we really run towards that. And that's how we thought, that's how we think, and literally we've been rewarded in the market for that, for believing that way. So we invest in trying to improve better outcomes. If you're talking about things like, well, let's make it a bit simpler to use or more attractive here and there, that one is something that I don't get too excited about, and I prefer to invest on outcomes. So, but in terms of you're not going to jump immediately investing $100 million or something like that. So what we do is we have different phases of development. We have a phase that I call exploratory phase. So we have the exploratory, then we have the technology development, and then the product development. And the exploratory phase is just pure research in general, and the goal is to answer a question. So if somebody has a question, hey, can this therapy or this approach provide better outcomes? So present it as a question, and let's find an answer to that particular question. Let's not develop a product for that necessarily. We can develop proof of concept and prototypes that are not necessarily that expensive, but let's try to answer that question. So the goal of that type of project is to find an answer. The goal is not to demonstrate that the answer is what we like. So success is measured as yes, no. Failure is I don't know. So in that mindset, it opens the people to explore because, people that are in there, they're involved like, okay, it doesn't matter what the outcome is, as long as I find the answer, I'm going to be successful. Yes, doesn't want to see it, and ideally, it's a fast-to-kill approach in terms of get me the answer as fast as possible, particularly if it's no. Then we go to technology development, which means you're starting investing into creating the capability from a knowledge perspective, but also from a technology perspective, the processes to build that new technology. And then you invest more in that one. Essentially demonstrate what is the limits. If you have to push the limits on something, then you have to understand what is it that you can do or not. And then the last part, once you know these two, then you can say, okay, now let's present a contract and develop a real product. And that's when you start getting a lot of people. But at that point, we have mitigated the risk. So does that make sense? We can take a lot of risk initially, but it's actually less expensive. And as you move forward, there is less risk, but it becomes a lot more expensive.
So, Rafael, read the paper, you may know where I'm going with this question. And I like your analogy I always use the language analogy, or music in your case. You've presented the percussion section. right? Pretty much
What's that?
You've presented the percussion section.
Yes.
So the rhythm, if you
Yes.
will. But my question is, how many other instruments do you have? And what I mean by that is, it's not just the rhythm, the pulse width, but what at least we're thinking, right, is it's also the analog component of this. It's the information across multiple axons. So do you have other flexibility in these devices for amplitude changing? What other flexibility do you have beyond just the bursting and pulsing?
Every single, so the answer is, I do believe that our system is the most flexible, just the limitations are not necessarily in the hardware, it's usually in the software, just to make it simple. So we can open up a lot more features that are not clearly evident. But for example, when we talk about the burst, every single pulse of the burst is actually controlled with the same Illumina software. So every single burst, every single element can use different contacts, different amplitude, different pulse width. It's a different timing channel completely. So you have full control on that one.
So
It takes manual programming though, but
Right,
you
so-
have it.
So in the real time, is there a continual data stream from your outside to the inside on this? Or
No.
how well do you program? What kind of programmability is on the internal?
So it's not.
Sorry, one other part of it, just to finish that question, is it driven by some input information, or is it open loop run? You basically can set a pattern and run it, or do you have other sort of input that comes into the system?
So right now you can you program the parameters and the IPG take those parameters and start going for it. So in terms of creating patterns that repeat in time or change in time, yeah, those are features that we can do, that we will do, but they are not necessarily available right now. Now the IPG has the set of parameters that you put in the remote control. You can put 32 different programs. So right now would be manual, essentially changing from one to the other one. But it's obviously something that we would change. Yeah, just because of the interesting waveforms. I agree with you. The language has to change, and how often is the question. So that's an area that we want to explore. But every pulse is significant. Per pulse perspective has significant improvements. And no, it's not continuous data stream. It just takes too much energy to maintain that. So, but if that's what is going to be required in the future, then it's probably one thing. So for the cochlear implants, that's what we were doing, right? Cochlear implants is continuous data stream because you're getting sound from the outside world and have to transmit continuously what you're trying to get. So yes, it's technology that is available that we could do. It's not typically what has been done in SCS.
So just one last little component of your flexibility. Is the waveform changeable, or is that established as well? In other words, is it always a square wave? Or can you change it to these other things that Warren and Cameron and various other people have come up with?
So right now, every pulse is a square pulse, but the element is right now. So they're common there. So by the way, our products we're part of the Brain Initiative in terms of went to the NIH and we put our products there to be available for any researcher that would be interested in using them as part of this initiative. So the thing is, and we would be willing to put some resources in terms of modifying the software or firmware or even hardware, I guess, to help in certain projects. But the problem is that the more that we have to touch, then the more difficult it becomes for us because we all have a project to do, right? So it's not that we have people hanging around the office. But essentially, I like to say that if there is something that you particularly want to explore, just let us know and say, hey, I want to do this. Can you help me do this stuff? And then we'll tell you. But there is a lot more flexibility than you would see in a commercial product within what we have or what we're going to have.
Ron, did you have a question? I think we're going to take time for one more, I think.
Thanks, Rafael. I admire your company's dedication to the patient. That's really important.
It is the only thing.
So this question I'm going to ask, just take it at face value. There are 250,000 people with spinal cord injuries in the United States, and has your company ever thought about motor system implementation of motor neuroprosthesis to help restore movement?
So the way that we work on indications is a little different than technology. So we're good at technology. This is let's say our uniqueness. This is where we can help. So, but indications, it's a very different type of beast. So I can make the systems that interface with the neural pathways, but I'm not necessarily the best at, or my team is necessarily the best at knowing what neural pathway do you want to choose to provide any particular indication. So the way I see it is an area where academia can help a lot more. So if you ask us, hey, would you be willing to modify your system so that we could run some studies in this type of patients and help us here? That's something that we would consider. In fact, we've done it already for SCI patients. We put our patients, we've provided devices to researchers that have to do it. I mean, we cannot do 500 devices a year or something like that. It's pretty expensive. I mean, I have to buy them in order to give them to you. I literally buy them from my operations to give them to you. But we've done it. So the answer is yes. We've actually done it, and so we had to get that the researcher comes to us and say, hey, you know what? I need some help in this type of system. Can you give me 3 or 4 or 5, and then we'll take it from there. So we have a research and we call the R&E committee, is the Research and Education Grants Committee, and they have to decide. First of all, do we have the budget, and second is valid research, and one element that we pay, I mean, it's incredibly strict, is we have to make sure that this type of contribution is not seen as giving you devices so that you can buy our products at all. We want to get no financial benefit. I mean, it has to be clear that we're not doing this to sell more products. So it has to be a very legitimate type of research process. So very careful in that one.
Rafael, thank you for coming.
Andy, thank you very much. Oh,
Just for you to remember your trip.
oh, fantastic.
This is a monument, so you're good. Thanks a lot.
Fond memories and boogie nights, huh? From Cleveland.
Thank you guys
Andy.
for coming.
Hey, thank you. By the way, you guys did a fantastic job reinventing everything in about an hour.